First, there are the cranio-thoracoscapular muscles, the first of which is the trapezius. It has three separate portions which can be distinguished on the direction of fibers. The descending portion is the most cranial portion. The fibers are directed obliquely and inferiorly. They emerge from the external occipital protuberance and the superior nuchal line through the superior aponeurosis. They also arise from the nuchal ligament, which extends from the external occipital tuberosity to C6 or C7, attached to the posterior edge of the superior aspect of the acromial end of the clavicle. This portion elevates the shoulder and tips the scapula laterally. The transverse portion of the trapezius, formed by parallel fibers perpendicular to the spine and arising from the spinous processes and supraspinous ligament from C3 to C7 via a triangular aponeurosis. These fibers attach to the acromial end of the clavicle, the posterior medial edge of the acromion, and the lateral third of the spine of the scapula, as well as the medial side of the acromioclavicular joint. The transverse portion is fixed to its origin on the cervical vertebra. It adducts and tilts the scapula laterally. The ascending portion of the trapezius originates on the spinous processes and the supraspinous ligament from T4 to T12 through the inferior aponeurosis. Trapezius is innervated by the accessory spinal nerve, also known as cranial nerve 11. It seems to have contributions from the spinal cord and the brainstem. These portions coalesce before passing through the jugular foramen together. The spinal accessory nerve then travels past the transverse process of the atlas, anteriorly in most cases, and then it descends medial to the styloid process and travels past the stylohyoid and digastric muscles. It runs along the superior sternocleidomastoid branch of the occipital artery and enters the deep surface of the upper portion of the sternocleidomastoid muscle. The accessory nerve exits along the posterior border of the sternocleidomastoid muscle. It can get contributions from the greater auricular nerve at this point. It then courses through the posterior cervical triangle by traveling on the surface of the levator scapulae muscle. It then travels to the anterior border of the trapezius muscle and forms a plexus at its surface, about 3 to 5 centimeters above the clavicle. This plexus also receives contributions from C2 and C4 ventral rami and enters the deep surface of the trapezius muscle. Most of the motor supply of the trapezius is from the spinal accessory nerve, with some contributions from the cervical plexus. Rhomboid muscles. These are flat, thin, rhombus-shaped muscles. They commonly form a single muscle mass, making it difficult to distinguish the rhomboid major from the rhomboid minor. The rhomboid major originates from the spinous process and the supraspinous ligament of T2 through T5. It attaches at the medial scapula, inferior to the medial end of the scapular spine. The rhomboid minor originates from the spinous processes and supraspinous ligament of C7 to T1 and inserts on the medial scapula, superior to the medial edge of the scapular spine. The action is elevation and adduction of the scapula. It also tilts the scapula medially, lowering the glenoid, which helps in shoulder adduction. And lastly, it stabilizes the scapula against the thoracic wall. The rhomboid muscles are innervated by the dorsoscapular nerve, which arises from the C5 nerve root, perforates the middle scalene muscle, and lies on the posterior scalene muscle. It continues in the dorsal direction beneath the levator scapula and rhomboids, which it innervates. The dorsal scapular nerve is close enough to the serratus anterior to occasionally provide some branches. The levator scapulae originates as 4 fascicles on the posterior tubercle of the transverse processes from C1 to C4. These fascicles coalesce and intersect at the superior angle of the scapula and the medial edge of the scapula superior to the rhomboid minor. The levator scapula elevates and adducts the scapula. It also tilts the scapula medially to lower the glenoid. This helps in shoulder adduction. The levator scapulae is innervated by the dorsal scapular nerve. The dorsal scapular nerve arises from the C5 nerve root, perforates the middle scalene muscle, and lies on the posterior scalene muscle. It continues in the dorsal direction beneath the levator scapulae and the rhomboids which it innervates. The dorsal scapular nerve is close enough to the serratus anterior to occasionally provide some branches. Serratus anterior. The inferior portion of the serratus anterior originates on the 5th through the 9th ribs. The fibers coalesce and attach to the anterior inferior aspect of the medial edge of the scapula, as well as its inferior angle. The serratus anterior fixes the scapula to the thoracic wall. It helps with forward motions of the scapulothoracic joint. This may elevate the glenoid, helping in shoulder abduction. The serratus anterior is innervated by the long thoracic nerve. This comes off the brachial plexus with contributions from nerve roots C5, C6, and C7. The course of the long thoracic nerve is as follows. It's formed by the anterior branches of C5, C6, and C7 just after they leave their respective intervertebral foramens. The branches of C5 and C6 perforate the anterior scalene muscles, while C7 is located on its anterior surface. The nerve continues vertically between the posterior scalene and the brachial plexus. It is located on the lateral aspect of the thoracic wall at the concavity between the subscapularis and the serratus anterior. The pectoralis minor. This is a triangular muscle located beneath or deep to the pectoralis major muscle. It originates as 3 separate fascicles on the superior and lateral aspects of the 3rd, 4th, and 5th ribs. Its fibers converge in a single tendon that attaches to the medial aspect of the coracoid process. The pectoralis minor and subclavius muscles are covered by the clavipectoral fascia, which attaches to the coracoid process, clavicle, and the anterior thoracic region. Like the serratus anterior, the pectoralis minor moves the shoulder forward. It can also act on the thorax while the scapula is fixed, like while manipulating one's trunk as they hang from a tree or monkey bars. The pec minor is innervated by the medial and lateral pectoral nerves, C6 to C8. The medial pectoral nerve arises from the medial cord at the level of the clavicle. It runs obliquely in an inferior and medial direction in front of the axillary artery and through the clavipectoral fascia and the pectoralis minor muscle, dividing into several branches for the pectoralis major muscle. It innervates both the major and the minor muscle. The lateral pectoral nerve. This arises from the lateral cord at almost the same level as the medial pectoral nerve. The lateral pectoral nerves give a branch that anastomoses with similar branches from the medial pectoral nerve. The deep branches of the lateral pectoral nerve reach the pectoralis minor muscle, and some of them perforate this muscle to innervate the pectoralis major. The latissimus dorsi is a flat, wide, triangular muscle located on the superficial aspect of the dorso-lumbar region. It has 3 fascicles, which coalesce into its insertion on the anterior aspect of the humerus. It originates on the spinous processes of T7 through T12 and L1 through L5, their supraspinous ligaments, and the middle sacral crest through the thoracolumbar fascia. It also originates from the external lip of the iliac crest, the 10th, 11th, and 12th ribs, and the inferior angle of the scapula. All the fibers coalesce into a tendon attached to the depth of the intertubercular sulcus and the crest of the lesser tuberosity. The latissimus dorsi adducts the arm through its action on the inferior angle of the scapula, which rotates and lowers the glenoid. It also extends and internally rotates the arm, while the limb is fixed. This muscle contributes to elevating the trunk and climbing. Contraction of both latissimus dorsi, or bilateral latissimus dorsi, causes trunk extension. This muscle also contributes to forced exhalation. It is hypertrophied in patients with respiratory conditions that are accompanied by frequent coughing. It is innervated by the thoracodorsal nerve, C6 to C8. The course of the thoracodorsal nerve is as follows. It arises from the posterior cord between the branches for the subscapular nerves. It is directed in an inferior direction over the subscapularis muscle, along with the thoracodorsal artery. It ends by innervating the latissimus dorsi.